EM board bombs.
Welcome back to EM board bombs. I beat you to it.
You did beat me to it. That was really fast.
Ladies and gentlemen, we're back. The team is back together. Dr. Hussain and I are here. Dr. Wasiski-Kuhn and I, the past couple of weeks, been knocking it out of the park.
Love it.
Where have you been?
I love the camaraderie. I love all of that. I've been, working clinical shifts, teaching, the next generation of learners.
That's what we're doing right now.
I know. But sometimes, they need a little one-on-one, one-on-one care. Hey, Briggs, there's a specific thing coming up here soon. Ugh.
Yes.
What is it called?
The ITE. Everyone's been calling me about it. I've had people from other academic programs calling me saying, "Hey, we're kind of worried about the residents."
Oh man,
especially with that board pass rate in December.
I know. I think a lot of people are a bit worried. But
out.
Hey, what we're gonna do is this is a special episode for geared a little more towards ITE. So instead of giving and focusing just on one question, what we're gonna do instead is do 15 pearls. We're going to go through 15 pearls relatively quickly so that we can do kind of some bulk teaching here. The first 5 pearls we're going to just make available on EM Board Bombs. Anyone can listen to it. And then the last 10 pearls we'll make available to our EM Rapid Bombs subscribers. If you want to subscribe to the premium podcast, go to emboardbombs.com, click the podcast section, and it's one-click sign up. We've got almost 500 podcast episodes, which are just high yield board content, 4 to 5 minute long episodes that you can just listen on repeat. And that'll basically, do well for you when it comes to ITE.
Totally. I'm excited. Hey,
let's go.
What's our only sponsor?
Oh, EM News. I almost forgot. EM News.
Absolutely.
Let's do this. So, you want to lead us in on the pearls? Let's do it.
Let's do it. I love this one. I still have a good fond memory of this one. Do you know why?
Why?
Because this is one of the few times in our podcast history that you recorded a podcast alone.
That's right.
You recorded this one.
I did.
I distinctly remember because I was at a conference in Arizona when this happened. And you text me and you're like, "Hey, I sent you that file. Did you have a chance to upload it yet?"
Yeah.
I'm like, I just got off the podium, but I'll get a chance to upload it. And I still remember looking at the thing. I was like, oh, this is a cool topic. This is a good one. Hey, so we have the case of a young patient, headache, seizures, vocal neurodeficits. What the heck? And the classic story, young female postpartum with lethargy and headache. Oh my gosh, there's only one answer for this on the test.
Only one. And they might ask you, in the way that they'll try to ask you this one too, is it's oftentimes like, what imaging modality? Negative CT head. Or they'll try to trip you up and they'll say, what imaging modality will essentially find your diagnosis, right?
That's good. I like that.
You know, because they'll assume kind of next step. They won't say that like CT non, and that's reasonable to get like a CT non-com, but they'll try to trip you up by basically saying, hey, what imaging modality will actually diagnose this? In the ED setting, right? And and what is that going to be?
This is a cerebral sinus venous thrombosis. There's like 3 different ways to call this thing. There's like 3 different names to it. The way I think of it though is a DVT for the brain. Same risk factors. Young females are usually more predisposed to this than young men, but it is young people. So think over birth control pills, cancer history, thrombophilia in general. The diagnosis here to get this right is usually a CT venogram because that's what you have readily access to. Available. It's like 90% specific, whatever that might be when the answer choice is. Or the other answer choice, the more accurate answer choice, is an MRI with venogram. So an MRV or MRA sometimes too. The plain CT, like we just said, is often normal. And so anyway, on the test, they're never going to give you both those options. They're going to just give you one or the other, the CT venogram or the MR venogram. That's the diagnosis. What's the treatment? So
treatment here is going to be heparin. Yeah. Even with hemorrhagic influx.
Yeah, that's the weird part. But
it's gonna be heparin. This is also one of those where they might give you in that stem this patient was just evaluated in the ER because this is oftentimes a diagnosis you're making on the second visit, right? So for a clinical kind of stem that you'll see, also oral boards, this is a good one to kind of review and do, is that patient was already seen, already had like a negative CT, and now they're back. And oftentimes, again, they're going to give those risk factors. They have to, which is like postpartum, OCP use, or some sort of prothrombotic state. That will definitely be mentioned in that stem. And again, you should be pushing for some sort of venous imaging here.
For sure.
And these patients are oftentimes having seizures, focal neurodeficits. The thing is, though, once they're having seizures, focal neurodeficits, the CT non-con oftentimes does show what the diagnosis is. But again, remember that in the stem, it's going to be one that was a patient that was already sent home, or it's going to be one with some of those key risk factors that we mentioned.
Cool. Let's move on here. That was a good first topic. Hey, we got a case here of an overdose, which you covered this already just recently on Rapid Bombs. So that's pretty awesome. Yeah. What do we have when we have a patient coming in with severe hypotension, bradycardia, and hyperglycemia? What is the classic overdose here from a certain type of antihypertensive medication?
Right, and I think that hyperglycemia part was key, and distinguishing between a calcium channel blocker versus beta blocker. This is more calcium channel blocker, right?
For sure.
With the hypoglycemia, that's how they'll try to give you that differentiation. If you listen to one of the recent Rapid Bombs on the premium pod, I really get into the weeds with this. You're going to be starting, the patient on IV fluids. You can consider some sort of vasoactive agents if you need. You can do calcium gluconate. Sure. Is that really going to help? I don't know. But what is like the main treatment modality, though, that they do expect you to know here? What is it?
So, yeah, if the things that you just mentioned already, they're not working, and they usually don't, you're doing high dose insulin therapy.
There you go.
And it's high dose. It's 1 unit per kilogram per hour, which is intense. You're also going to, slam some glucagon, hope for the best, vasopressors, whatever. And then last resort is a lipid emulsion therapy here.
Yeah. But really what they want you to know, and
is
they're really pushing you toward, is, there you go.
Definitely.
High dose insulin therapy for these.
Yeah.
Remember, the key distinction here is that hyperglycemia, and it's going to be likely calcium channel blocker versus beta blocker overdose. All right. So next one, breaks.
Yeah. So next one here, we have a patient coming in with fever. And this is just going to give it away here. Muffled hot potato voice.
I know.
And then unilateral throat pain. Okay, sure, got it. Maybe you might as well throw in the uvular deviation too, right?
Do it.
This patient has what?
It's a peritonsillar abscess.
Yeah,
right?
For sure. We think young people usually for these, like, teenage years to the 20s and 30s. Usually not little toddler children have this. Toddler children have more of an RPA, retropharyngeal abscess.
That's not good. Oof.
No, it's not good. Those are much less happy than the PTAs. PTAs, you seem like, oh, okay, good, we can manage this. Diagnosis here is clinical. I feel like so often nowadays we get CTs on these when in reality you don't have to get a CT on these when it's straightforward. The treatment is going to be needle aspiration with an IND plus antibiotics. On the test, they're going to want you to do IND, and then they're going to want you to do antibiotics. They will sometimes want you to do IV antibiotics. Obviously, if they're unwell appearing, febrile, vomiting, whatever, they should stay in the hospital after that IND, and they get ampicillin, sulbactam, or clindamycin. If they're going home, what is the regimen?
Yeah, I mean, if they're going home, you're going to be, again, antibiotics, but also steroids are going to be.
And what's the antibiotic?
Augmentin.
Yeah, for sure.
You can get away with Augmentin, with these. And again, steroids, can't emphasize that enough. Steroids oftentimes help.
All right. Hey, next one here. We have a patient coming in. They're seizing. Obviously, the first line medication to anyone in the world should know this. Even a colorectal surgeon. Any seizure lasting greater than 5 minutes, you're doing benzodiazepines. Lorazepam 4 milligrams IV or midazolam, high dose. If seizures persist, you're escalating to what?
So you have phosphophenatoin, you have Keppra, valproate you can give, but again, your first line here is going to be benzos, and then it's going to be more benzos.
Yeah.
And then you're thinking about other things.
Yeah. 2 doses of benzos.
Yeah.
And and if they have a moment where they've recovered and they're like alert and oriented, but then they go back into having seizures, you kind of reset that pathway. You're going back down that road again and saying, okay, benzos again,
right,
and then load. Let's be honest, in real life, most of the time these patients get loaded anyway. But on the test, at least, they're going to tell you this is the correct order to go in. Let's say you do all that stuff and it doesn't work. What are you doing then? Give 2 benzos, gave the letracetam, Keppra.
Right. You gave everything, and then this is the patient. They're going to make abundantly clear in that stem that nothing is working.
Yes.
Right? So you're thinking status here, and then you're going to be reaching towards intubation. Propofol, is going to be one of the drugs that you consider using.
For sure. Awesome. Next one here, we have a patient coming in with a Tylenol overdose, acetaminophen toxicity. What is the only antidote to this? And this is probably one of the greatest antidotes ever invented.
Yeah. You can
so effective.
kind of pick it up over the counter too, but it was just kind of funny too, right?
Yeah.
So it's really
it's
gonna
not
be
charcoal
NAC.
for those of you listening.
I know. So it's really going to be NAC, and that is 100% effective in preventing liver failure. N-acetylcysteine, if it's given within 8 hours.
Yeah.
Hey, one thing I can guarantee you they're going to ask you on boards, it's going to be this. Just know it. I mean, this is a bunny. You need to know this. And then can you get into some of the ways you might get tripped up? So the antidote is going to be NAC.
Right.
And talk about the nomogram.
Yeah, there's this Rumac Matthew nomogram. You use that to help determine, based on the level and the approximate time they ingested, whether or not you should give NAC, basically. Now, if there's a chronic overdose, let's say the patient's like for a month been taking high doses of Tylenol, and it's unclear timing in the patient. These are, of course, more obviously accidental. The chronic ones are like, hey, I'm just taking Tylenol because I'm in pain, or I've been taking it for weeks. You're going to start NAC in general if they have any elevation of the AST and ALT. But I don't want to say anything more about that because chronic overdoses are just never going to be tested, and they're frankly just uncommon. And you're not going to catch those probably. So what the more important one is this purposeful, massive Tylenol overdose. So they come in the ED. Right. If you know the timing that they took it, like they said, hey, I literally took it right before I got here, then you're going to get a level in 4 hours. In reality, we often don't know and or don't trust what the person has said. And so we usually get a level right away when they come in, and then you do 4 hours from that suspected overdose time. And that's two different levels to match and compare to the Rumac Matthew curve. Yeah.
So I think the key that we're saying here is knowing the time to get the lab, right? They might test you on that, right? So can you explain that again one more time? When do you get the labs?
You should get it right on arrival to the ED, and then you should follow up with one 4 hours later.
There you go.
From that time, or 4 hours from when the patient told you that they ingested.
Right. Perfect. Hey, next one.
Hey, we're done with these 5 for the main podcast.
Oh, that's right. Okay.
That's if you want to, we've already hit it.
We've hit it, and then if you want to listen to 10 more that we're going to drop, 10 more pearls, and
10 more pearls and 485 or so other episodes.
Yeah, if you want. You're right. If you want almost 500 episodes, go to ianboardbombs.com and
check it out.
Just click the podcast section, sign up.
We're not going anywhere. We're staying here.